Welcome to my channel, Integrated Med Notes. In this video, I will discuss hypertrophic osteoarthropathy, or HOA. Let's just break down the term here. Hypertrophic means excessive growth due to connective tissue deposition, but overgrowth where? Osteo refers to bones and the arthro is referring to the joints. So in hypertrophic osteoarthropathy, there is abnormal growth in the bone and joints. Hypertrophic osteoarthropathy is characterized by the triad of clubbing of digits, painful long bones, and symmetric bilateral painful arthropathy. Hypertrophic osteoarthropathy is a paraneoplastic syndrome associated with lung cancer. The painful arthropathy is due to joint enlargement and synovial effusions, for example in the wrist joints. The pain in long bones is due to periostosis, which is an inflammation of the periosteum or periostitis, followed by new bone formation and periosteal thickening. Periosteum is the outer layer of bones. This periosteal reaction can be seen on imaging as an increased uptake on bone scan or PET. The periosteal new bone formation involves, for example, the tibia, fibula, radius, and ulna. Digital clubbing is thickening and widening of the nail bed and digital phalanges, giving the fingers a bulbous, broomstick appearance. This is due to connective tissue proliferation at the nail bed and distal phalanx. The base of the nail feels spongy when compressed, and this is due to increased fibrovascular tissue under the nail. Clinically, clubbing is assessed by measuring the Lovi-bond angle. This is the angle between the nail bed and nail plate. Normally, this angle is around 160 degrees. Clubbing is diagnosed when it exceeds 180 degrees. Additionally, in clubbing, there is loss of the normal diamond-shaped window called Schamroth's sign. This window can be appreciated by having the patient place the dorsal surface of the distal phalanges of the fingers together with the nails opposing each other. Normally, an open area is visible between the bases of the opposing fingernails. When clubbing is present, this open space is no longer visible. Digital clubbing may be hereditary or acquired. There are various secondary causes of digital clubbing. Digital clubbing is associated with intrathoracic neoplasms, such as bronchogenic carcinoma, in which adenocarcinoma is the most common, lung metastasis, malignant mesothelioma, and lymphoma. Lung disorders associated with digital clubbing include interstitial lung disease and pulmonary arteriovenous malformations. Digital clubbing is also associated with cyanotic congenital heart disease. Intrathoracic suppurative infections associated with digital clubbing include bacterial endocarditis, empyema, lung abscess, bronchiectasis, for example, due to cystic fibrosis, and cavitary infections, such as fungal or mycobacterial. Less frequently, digital clubbing may occur in patients with extrathoracic disease, including inflammatory bowel disease, liver cirrhosis, and gastrointestinal neoplasms. Importantly, chronic obstructive pulmonary disease, COPD, and asthma are not typically associated with clubbing. Therefore, the presence of clubbing in a patient with COPD should prompt evaluation for occult malignancy, starting with a chest radiograph. Clubbing is almost always a feature of hypertrophic osteoarthropathy. On the other hand, clubbing can occur by itself without hypertrophic osteoarthropathy. Both clubbing and hypertrophic osteoarthropathy could be different manifestations or stages of the same disease process. So what is the pathogenesis of hypertrophic osteoarthropathy? The pathophysiology is unclear, but there are two proposed mechanisms, both involving growth factors. One mechanism is that tumor-derived growth factors, such as vascular endothelial growth factor, VEGF, stimulate growth. The second proposed mechanism is related to megakaryocytes. Under normal conditions, megakaryocytes are fragmented in the pulmonary circulation. However, when the pulmonary circulation is disrupted by tumors or chronic lung inflammation, the megakaryocytes skip or bypass the normal fragmentation and enter systemic circulation. Due to their large size, they become entrapped in the capillaries of the distal extremities, where they interact with endothelial cells and release platelet-derived growth factor, PDGF, VEGF, and other factors. The cumulative effect of these mechanisms is the activation of hypoxic inflammatory pathways, with subsequent release of platelet-derived and fibroblast-derived growth factors such as PDGF, VEGF, and TGF-beta. These growth factors promote local fibrovascular growth in the fingertips through periosteal new bone and connective tissue formation by activated fibroblasts, angiogenesis, and edema via increased capillary permeability, ultimately leading to clubbing and periostosis. The treatment of HOA aims to identify and treat the associated disorder. The symptoms and signs of HOA may disappear completely with removal of the tumor or with antibiotic therapy for a chronic pulmonary infection. Additionally, nonsteroidal anti-inflammatory agents or analgesics may help control symptoms of HOA. Thank you for watching this clinical overview. If you found the video helpful, please like, share, and subscribe, and don't forget to leave your comments below. Until next time, happy studying and good luck.